Welcome everyone. So in this session, we are going to discuss the questions that were asked in this year's NEET SS medical group related to the Department of Pulmonology. So I'm Dr. Ayush and we'll discuss the questions one by one. So coming first to the weightage. So close to around 7 questions were asked from pulmonology in this year's exam, out of which 1 question was asked on COPD, 2 questions were asked from asthma and ABPA, and there were around 4 questions that were based on interstitial lung diseases. And you can say that some of these questions had an overlap with rheumatology. So only 7 questions in total, which is not a lot, but most of these questions are relatively easy and straightforward, which you could have answered had you studied the topic. So let us talk about these questions one at a time. So the first question that was asked on COPD was, there was an elderly male who was a chronic smoker with shortness of breath and productive cough. So the PFT showed that the FE1 by FVC ratio was 65% and the FE1 value was 55%. So the question that was asked is, according to Goel criteria, which class does the patient fall into? So we had covered this in our topic on COPD. This is from our recorded lecture. So as we know, Goel classifies COPD into 4 categories, that is mild, moderate, severe and very severe. So if the FE1 value is more than 80%, that is known as mild COPD. If the FE1 is between 50 to 80%, then that was moderate COPD. If the FE1 was between 30 to 50%, it's severe COPD. And if the FEV1 is less than 30%, it is very severe. So the answer to this question would be moderate COPD. So this is a relatively easy question. And this is also from Harrison. It was given in page number 2182. So apart from the Goel classification based on FEV1, you should also know the ABE classification, which is on the basis of the symptom burden and on the basis of the exacerbation history. So the Goel classifies into A, B, and E category. The next question that was asked was that there was a young boy with shortness of breath and wheeze. So it was said that the patient was kept on anti-asthmatic medication with no significant improvement. And later the patient had some skin lesions for which he was started on antifungals by the dermatologist. And after taking these antifungals, the patient actually reported improvement in both the skin and respiratory symptoms. So some of the framework of the questions might be different because all these are memory-based recalls and the options might also be different. So if you guys remember the exact questions or the options, then you can always message me so we can update the questions. So if we understand this question, so there's a patient who has some history of asthma. He's not getting better with standard treatment. And when he started on antifungals, the patient is getting better. So you're looking for a disease which is going to improve with the use of antifungal therapy and a disease which presents like asthma. So if we look at the options, then the first option, that is ABPA, is the right answer because the patient will have allergic symptoms, will have shortness of breath and wheeze. And as we know, one of the treatment modalities for ABPA is the use of antifungal agents like itraconazole. Although it is not the first line of treatment, it is usually used when the patient relapses even after use of steroid therapy. One way that I like to solve questions is, apart from just taking the right answer, always read all the other options that you have and try to tell yourself why the other options are not the correct answer. If you're able to exclude the other options, then you'll always be more confident of taking your correct answer and you'll not make silly mistakes. So if we look at the other options that we have, the second option was fungal pneumonia. So firstly, the presentation of fungal pneumonia is going to be very different from what this boy is having. There is no immunocompromised state. The patient is only having shortness of breath and wheeze. The patient is not in a severe disease state like a fungal pneumonia should present. And that is why fungal pneumonia is not the right answer, because the clinical presentation is going to be completely different. If you look at the third option, that was eosinophilic interstitial pneumonia. Then as we know, eosinophilic interstitial pneumonia, the treatment of choice is steroids, and the patient dramatically improves with steroids, and there is no role of antifungal therapy because there is no fungal allergy in the patient. So we had discussed the treatment of ABPA in our talk on ABPA. And as we can see here, in the acute stage of ABPA, the treatment is steroids. And if the patient relapses, even after the use of steroids, then we can use steroids plus itraconazole, which was what was used in this patient, and the patient showed improvement. So the correct answer to this question would be ABPA. Also, even Harrison mentions this, which is given in Harrison page number 2165. Harrison mentions that both systemic glucocorticoids as well as azoles therapy can be used for the treatment of ABPA, and most of these patients will show response. Coming to the third question was based on immunology, or also you can say it was based on asthma. So the question was, T2 inflammation is mediated by which of the following cytokines? And these were the options. So when we talked about asthma in our lecture, then on the pathogenesis, we discussed that asthma could be of two types based on the type of inflammation. It could either be a T2 high asthma, or it could be a T2 low asthma, that is non-T2 high. So when we talk about T2I asthma, that was based because of the involvement of Th2 cells and the innate lymphocyte 2 cells, and the main cytokines that are used is IL-4, IL-5 and IL-13 along with TSLP. So these are the four cytokines that are responsible, IL-4, IL-5 and IL-13. When we talk about the T2 low asthma, then we discuss that Th17, IL-17 and TNF-alpha, interferon gamma are the main cytokines of the non-T2 high or T2 low asthma. So the correct answer to this question would be IL-4. So this is relatively a newer concept in asthma, where we are looking at the type of inflammation, because this helps us decide whether or not the patient is eligible for biologicals. Nowadays, more and more patients are being prescribed biologicals for their severity of their asthma. Again, even in Harrison, when we read the asthma chapter, then it speaks about T2 high cytokines, in which again it is mentioned that IL-5, IL-4 and IL-13 are the major cytokines associated with type 2 inflammation. Coming to the next question, question number 4. So in this, we had a 45-year-old male patient who presented with chronic cough and shortness of breath. So the patient is having chronic cough and shortness of breath. On examination, the patient had infrascapular crepitations. The CT scan was mentioned that it was showing a UIP pattern ILD, and the question was, which of the following is the least likely diagnosis? So you had a 45-year-old male patient who had ILD, and the pattern is important because it says that the patient has a UIP pattern of ILD. So these are the four options. So when I spoke about CTD ILD in my talk, so this was a table that we are referring to, which summarizes the findings that are seen in the different CTD diseases related to the lung. So if you carefully look at this table, then when we talk about UIP pattern, so UIP pattern can be seen in RA, and UIP pattern can be seen in systemic sclerosis. And we all know that UIP pattern is the hallmark of idiopathic pulmonary fibrosis. So coming back to this question, so we know that RA can show UIP pattern, we know that SSC can show UIP pattern, and we know that IPF has UIP pattern as its hallmark. So if we exclude all the other options, the correct answer for this question would be sarcoidosis. Again, if we talk about Harrison, then in Harrison, if we read the table mentioned in the chapter for ILD, then again, it mentions that both in IPF, you will have UIP pattern, as well as in systemic sclerosis, you can have UIP pattern ILD, although it's not the most common pattern. The most common pattern is NSIP. And in its text, it mentions that UIP pattern ILD can be seen in IPF as well as in RA-associated ILD. The correct answer for this question would be sarcoidosis, which usually shows an upper lobe predominant nodular pattern, and the nodules are usually peribronchial or in a lymphatic spread. The next question again that was on ILD was that the patient had a rapidly progressive interstitial lung disease. Which of the following antibodies or myositis antibodies is associated with a rapidly progressive ILD? And there were 4 antibodies, all of which are associated with myositis, were given as the choices. So again, when we spoke about myositis ILD, so this was a table that I made. So this summarizes the findings that can be associated with a specific antibody. So if we carefully look here, then when we talk about MDA5, then MDA5, the patients can present with an acute to a subacute lethal ILD. So anti-MDA5 patients actually have amyopathic dermatomyositis. There is no myopathy, but apart from that, the patients actually have painful ulcers. The patients present with an acute, rapidly progressive lethal ILD. The patients have pneumomediastinum, and the patients have ulcers over the extensor surfaces. This is anti-MDA5. So the correct answer to this question would be anti-MDA5 ILD. If you look at the other options, then anti-Jo1 is associated with anti-synthesis syndrome and can also have an ILD, but anti-MDA5 usually has a more rapidly progressive ILD. When we talk about anti-TIF, then TIF actually is associated only with dermatomyositis. It is not associated with ILD. And again, the same for MI2, again associated with myositis, but not associated with ILD. Again, if we talk about Harrison, then in the chapter on myositis, this is what Harrison mentions, that anti-MDA5 antibodies are associated with severe rash and rapidly progressive ILD. So we can see that most of the questions, the answers are mentioned Harrison, but it is somewhere hidden inside the text or hidden in tables and might not be very readily available to you when you read these topics. So we have covered most of these things in our lectures on pulmonology. Coming to the sixth question. So you had a 42-year-old female patient who had diffuse cutaneous systemic sclerosis, and it is said the patient is having an ILD. The FVC value mentioned was around 50%. The DLCO was 30%, and it was saying that ECG and imaging is showing right ventricular hypertrophy along with dilated PA that is suggestive of pulmonary hypertension. And the question says, which is the most appropriate next step in management? So we have a patient of diffuse cutaneous systemic sclerosis with a FVC value of 50%, and the patient is also having PAH. And the question is, what is the next most appropriate step? Then again, let us see one option by the next. So the first option is start systemic steroids. So we all know that systemic steroids is not used in patients with systemic sclerosis, the reason being because of the risk of renal crisis. So we can discard this option. The next option is start cyclophosphamide. Okay, we'll come back to this. The next option is refer for lung transplant evaluation. So till now, the patient has not received any treatment. So without giving any treatment, we will not refer the patient to transplant. We'll first give the patient some form of therapy, look for the response, and if there is no response, the patient has a progressive disease, then you go ahead with a lung transplant evaluation. So again, this is a wrong option. The last option is start endothelin receptor antagonist. So the patient does have PH, right? So some of you might think that starting endothelin receptor antagonist, or for that matter, any PH specific therapy might be the correct answer. But look closely, the patient has a diffuse cutaneous systemic sclerosis. So in our lecture, we discussed that when the patient has diffuse cutaneous systemic sclerosis, the pH that happens is actually a type 3 pH, that it is secondary to the lung disease. Whereas when we talk about limited cutaneous systemic sclerosis, then the pH that happens is a type 1 pH. And when we discuss pulmonary hypertension, we all know that when we talk about pH specific therapies, like we talk about endothelin receptor antagonists, or we talk about PD5 inhibitors, right? So all of these therapies are only and only approved for group 1 pH. They're only approved for group 1 pH. When we talk about group 3 pH, the treatment of group 3 pH is only treating the underlying lung condition, and there is no role for these pH specific therapies. So this patient has diffuse cutaneous systemic sclerosis. Therefore, there is no role of a pH specific therapy for treating the pulmonary hypertension in a patient with diffuse cutaneous systemic sclerosis. So even if you don't know the correct answer, by removing the three options, we know that option B, that is start cyclophosphamide every 2 weeks, is the correct answer. So when we discuss about SSC ILD in our session, so the treatment of SSC ILD is actually determined by the extent of involvement in the patient. So if the CT scan shows that more than 20% of involvement is present, then the patient needs treatment. If less than 10% involvement is there, then no treatment is needed. Whereas if there is 10 to 20% involvement, then you look at the FVC. If the FVC is less than 70%, then again, the patient needs to be treated. So in this scenario, our patient has an FVC value of 50%, which is less than 70. Therefore, the patient requires treatment. And when we talk about the treatment modality, then steroids need to be avoided, and the treatment of choice is cyclophosphamide, MMF, or rituximab. Either one of these three agents can be used. So in our question, the agent that we had was cyclophosphamide, and therefore that was the correct answer. So this was what we had discussed in our lecture. If we talk about Harrison, then again, this is what is mentioned in Harrison. So in text, it mentions that cyclophosphamide has a modest benefit in preservation of lung function and therefore should be used in patients with SSC-ILD. And if we talk about the algorithm that is mentioned in the systemic sclerosis chapter, then again, if the patient has a FVC of less than 70%, then therapy needs to be initiated with either MMF, cyclophosphamide, and the newer agent that is rituximab. Coming to our last question. So this question was based on rheumatoid arthritis. So we had a 60-year-old male with RA who was on methotrexate for 5 years and is now presenting with shortness of breath and cough. So on examination, the patient had end inspiratory crackles. The HRCT was written to be showing reticular opacities and traction bronchiectasis suggestive of an UIP pattern. And the question was, which of the following is a correct answer? So again, let us come by one option by the next. The first option was methotrexate-induced fibrosis is very common. So sometimes simple common sense is enough to answer your questions. So most common drug that is prescribed for rheumatoid arthritis is methotrexate. So had methotrexate-induced fibrosis been very common, then all of you would have seen these patients in your practice, but this is not so. Therefore, methotrexate-induced fibrosis is actually a rare event. It is not a very common ILD. So again, this is a wrong answer. The second option was honeycombing on CT is suggestive of irreversible damage. So even if you don't know specific to RA, all of you, I'm sure, know that honeycombing is a feature of UIP pattern or a feature of idiopathic pulmonary fibrosis. And as we all know, it is a disease which keeps on progressing and it is an irreversible disease. So honeycombing on CT is actually suggestive of an irreversible damage. If we come to the third option, then end inspiratory coarse crepitations are a typical finding. So from your MBBS days, from your MD medicine exams, on your practicals, we all know crepitations could be fine crepitations and coarse crepitations. Fine crepitations are usually seen in patients with pulmonary edema or in patients with interstitial lung disease. So what ILD patients have is a fine crepitation. Whereas if we talk about coarse crepitations, then coarse crepitations are usually seen in patients with bronchiectasis. So again, nothing very extraordinary about this. All of you would have known that this option was wrong. It had to be end inspiratory fine crepitations. And the last option is this condition is likely to respond well to steroids. So when we talked about RA-ILD in our lecture, so we talked about the prognostic factors of RA-ILD. So we said that UIP is the most common pattern of ILD seen in RA, but UIP pattern is associated with a poor prognosis. So as we know that UIP patterns are associated with poor prognosis, therefore this means that these patients do not respond well to therapy and therefore they have a poor prognosis. So again, by cancelling all the other options, we know that the right answer is that honeycombing on CT is suggestive of irreversible damage. So this was all about the 7 questions that were asked on pulmonology in your NEET SS medical group. If there's any question that I've missed or some of the questions that I've mentioned here were different from your exams or the options were different, or if you have any queries, please feel free to reach out to me. So pulmonology as a whole is not a topic which has a lot of weightage in your medical group, primarily because there's a separate group for pulmonology, but still 7 questions is a good enough number, and most of these questions were straightforward. Most of these questions had answers that were mentioned in Harrison, but they were hidden in the text or hidden in below the diagrams or inside the diagram. But we have covered each and every question in our lectures previously as well, because we understand what is important and we discuss them in more detail with concepts that you can remember. So this is all about today's session. Please feel free to reach out to me if there is any queries. Thank you.